Cryptorchidism is undescended or hidden testes, which can occur one or both testes that fail to descend through that inguinal canal into the scrotal sac. Congenital cryptorchidism is a common urological problem, with approximately 4.5% of normal healthy boys having at least one undescended testes discovered at birth. Premature infants have a significantly higher incidence, and that's about 30%. It's usually seen more frequently in low birth weight or smaller than average length newborns. Most newborns have spontaneous descent of their testes during the first 6 months of life. And make sure that you know that children with undescended testes are at increased risk for testicular malignancy and infertility. And that exposure to the testes to the heat of the body leads to low sperm counts at sexual maturity. So it's a good history taking, especially if a young man comes in and they haven't been able to have children. So that would be one question that you would ask. Remember, they also are at greater risk for torsion and trauma, frequently associated with an inguinal hernia. And the clinical manifestations, the testes are not palpable, nor are they easily guided into the scrotum. And we can, when we look at our diagnostic evaluation, we look at whether one or both of the testes have been undescended. If the testes not palpable, in some instances, we'll go ahead and do an ultrasound, CT scan, MRI to determine the location. And it's interesting because the missing testes can be found at any point along the process vaginalis, which may be located in the abdomen, or it may follow an apparent course and come to lie in the inguinal area, maybe the base of the penis or the perineum. It can also be in the intra-abdominal. We may find testes which may require exploratory surgery by lap, or an orchiopexy may be performed. When neither testes can be palpated, the child may be evaluated for their presence by hormonal stimulation and the measurement of testosterone response. If they have an elevated FSH and LH levels accompanied by absent testosterone, that could indicate testicular absence, and true absence of both of the testes is very, very rare. Well, initially, the infant with undescended testicles is managed by observation, because usually there's that spontaneous descent during the first 6 months of life, and that's very common. If the condition persists, they can do an orchiopexy, is performed to bring the testes down into the scrotal sac and suture it in place. That's usually done by lap approach, and the most common complications to that surgery is bleeding and infection. The optimal time for surgery is usually up to the physician. They usually say that increased frequency at 6 months of age is common, but no later than ages 9 to 15 months of age. And the purpose of that is, of course, to reduce the risk of infertility and malignancy. And it's always important to teach the male adolescent to perform testicular self-exams throughout life to screen for any kind of malignancy. So our nursing care of this child will under our nursing diagnosis is deficient knowledge, especially parenteral, related to the cause and the management of undescended testicles, and the risk for ineffective health maintenance related to possible decreased fertility and increased risk of testicular cancer or malignancy. So under our nursing care, it should be directed at educating parents and providing them with information and resources. And if the child has bilateral undescended testes or absence of testes, make sure to refer to a counselor, psychologist, or a specialist may be appropriate. It's important to monitor after an orchopexy the patient's voiding patterns at the pain level of the child or the infant, and swelling or any signs or symptoms of bleeding or infection. Now we're going to be talking about vesicoureteral reflux. And just remember of the anatomy that there's a wave-like mechanism at the junction of the ureter and the bladder, which prevents urine reflux into the ureters. So as urine fills the bladder, or as the bladder contracts during voiding, pressure in the bladder occludes the opening to the ureter, so we don't have reflux. But when a defect occurs at the vesicoureteral junction, then we'll have what they call VUR, which is vesicoureteral reflux. And that results from that. That's that primary reflux, usually from a congenital anomaly that affects that junction. Secondary reflux can be associated with a lower UTI is also possible, and that's just transitory VUR. Reflux with infection is the most common cause of pyelonephritis in children, and it's the same type of signs and symptoms that we see in UTI. And you may see those clinical manifestations of pyelonephritis, which is more of a systemic infection than a UTI in the bladder. On page 461, there's an international classification of reflux, and it's graded. It shows you the normal on the very far left top, and it shows you the mouth. There is a valve from the ureter into the bladder. And then grade 1, you'll see there's reflux up into the ureter only, and there's no dilation. Grade 2, we see reflux into the ureter, the pelvis, the calces, with no dilation, and normal calceal fornices. Grade 3, we have mild dilation of the ureter and mild dilation of the renal pelvis. And then grade 4 and grade 5 are worsening refluxes into those into the kidney. You don't have to know the international classification of reflux, but you can appreciate, I think, from this picture of the severity if untreated, and which would lead to kidney failure. So it's divided, and this slide just goes over the division of the different grades of vesicoureteral reflux. And there's grade 3, 4, and 5, as mentioned before, and you can see on page 461. Here's some diagnostic tests that they'll do. They'll do a urinalysis and a urine culture, do electrolytes, BUN, creatinine, imaging studies. Usually plan about 3 to 6 weeks after the infection to allow for any infectious inflammation to subside. Then they'll do an ultrasound avoiding cystourethrogram. So this slide kind of gives you some ideas of what they do with the different grades. Grades 1 and 2, they do continuous low-dose antibacterial therapy with frequent urine cultures. Grade 3 is managed with antibiotics unless complications are present. And then grade 4 and 5, excuse me, grade 4 and 5, may require surgical intervention. So nursing considerations: explain the treatment plan, help the patient and family with that treatment plan. Explain that medical management may last for years. Adherence to antibiotics is very, very important. And if surgical intervention is necessary, educate, pre-op and post-op repair. And that will come from your physician orders. Okay, we're going to stop at this one. Just wanted to refer you to page 463. It's the patient-centered teaching and how to manage and prevent urinary tract infections. And this is great teaching for our parents, and making sure that they do prevent urinary tract infections, and how important it is to follow up, make sure the antibiotics are given for the full number of days that's been ordered. Usually they have to have a follow-up urine culture to the lab, especially if the physician or nurse practitioner has requested one. Keep the follow-up appointments, and make sure that you call the nurse practitioner or physician, the healthcare provider, if the child has a fever or any symptoms that may make you think that the infection has returned. Preventing UTIs from recurring is important because repeated infections, as you know, can cause kidney damage. And here's the suggestions are bulleted in the box under patient-centered teaching. But make sure you teach parents to wipe babies and teach young girls to wipe from front to back after going to the bathroom. Make sure to keep the foreskin on uncircumcised baby boys as clean as possible. Encourage your toilet-trained child to avoid holding urine and to urinate at least 4 times a day, and completely emptying the bladder. Parents are told to give their child lots of fluids throughout the day to help flush out the bladder. Avoid dressing the child in tight clothing or diapers. Use cotton underwear rather than synthetic fabrics. Avoiding bubble baths, which can irritate the urinary system. And emphasize proper hygiene, especially if they have a daughter who's sexually active, and encourage her to urinate immediately after sexual intercourse. And then we'll go on in our next web link onto some more congenital abnormalities. Now we're going to be talking about the pediatric disorders with a genitourinary alteration. This is the anatomy of the genitourinary system in a little girl, and she looks about age 4 to 7 maybe years of age. So you can it tells you a little bit about the placement of the kidneys and the ureter and the bladder. There are some differences in the genitourinary system. Complete maturation of the kidney occurs usually between 6 and 12 months of age, and before this time the filtration capacity of the glomeruli is reduced, so urine is voided frequently and has a very, very low specific gravity because of that glomerulus filtration rate being reduced. So it's like they can't concentrate urine. Fluid constitutes a larger fraction of an infant's and small child's total body weight. The kidneys are less efficient at regulating electrolyte and acid-base balance and eliminating some drugs from the body. The maturity of those renal structures predisposes the infant to dehydration and, of course, fluid volume excess. Bladder capacity increases usually from about 20 to 50 mLs at birth to about 700 in adult. The innervation of the stretch receptors in the bladder wall does not occur before the age of 2. So that kind of gives you an idea that when that at least has been matured, you're going to have that child feel that sense of fullness. So, and before that, they won't. The urethra is shorter in children than in adults and may contribute to the frequency of UTIs that you especially see in children. Kidneys are more susceptible to trauma in children because they do not have as much padding as you and I do, as we all know. Well, especially me. I don't know about you, but especially me. So some of the diagnostic tests and assessments of the renal system that you'll see, of course, is the urine specimen for analysis. It can be a clean catch or it can be a sterile. IVP, radiographs of the kidneys, ureters and bladder, renal bladder ultrasound, cystograms, CTs, voiding cystourethograms, and MRIs. On page, this is chapter 20 in your PEDS book, The Child with a Genitourinary Problem, and on page, let me just refer you to it real quick, is the common labs and diagnostic tests, or on page 456 if you wanted to follow along. But I think it's important that you have a basic understanding of what's normal for specific gravity. And if it's high, what does it mean? And if it's lower, what does it mean? The pH sometimes is altered by diet. Usually it's 4.5 to 8. Glucose, detection of glucose in the urine. We should not detect glucose in the urine. And we really want to make sure that we do just a simple urine dipstick, especially if the child has been having problems with enuresis, nocturia at night. Make sure they're not a diabetic. We want to check for ketones. And children are more prone to development of ketouria, so we want to make sure that that's negative. Leukocyte esterase, that's just the enzyme that is released during the white blood cell breakdown, and that should be negative. If it's positive, it may indicate that there's a possible UTI. Are nitrates produced by select bacteria? That should be negative, and when it's positive, it usually means that there's some bacteria in the urine. White blood cells, usually seen with infection. Urine culture is usually indicated for that. Red blood cells, it's very normal in menstruating females, but it could mean that there's trauma, stones, infection, or glomerulonephritis. Bacteria, there should be none in the urine, and if there is, it's indicative of a UTI, and a culture should be done to see what kind of organism and what sensitivity there is for which antibiotic. Casts are just WBC casts and red blood cell casts that originate in the kidney tubules. Usually indicate if they're present pyelonephritis, glomerulonephritis, some kind of renal infarct, collagen disease, interstitial inflammation of the kidney, and urine, of course, urine culture and sensitivity, presence of bacteria. It should be negative or less than 100,000 colonies per ml of urine from the clean catch or a sterile specimen. Usually, if it's indicated, there's isolation and identification of pathogens in that urinary tract, and then there's identification, of course, of antibiotic sensitivity. Serum studies, of course, will BUN. That's the end product of protein metabolism, blood, urea, and nitrogen. Nitrogen's that end product, and usually increases in renal insufficiency. Your serum creatinine is byproduct of muscle metabolism production, and it's usually constant as long as the muscle mass remains constant, and it should be assessed before giving any kind of nephrotoxic type agents. And of course, as you know, it increases in renal insufficiency. It goes into the different radiographs, your kidney, ureter, and bladder. Cystoscopy, and they go up and they examine the bladder and the lower tract to see if there's any tumor or stones. Of course, CT of the scan, CT scan to check for any renal tumors. Voiding cystogram voiding cystourethrogram. It detects reflux of urine into the ureters and its severity, so that at that VE junction we talked about the other day. Renal ultrasound assesses the position, the size, the contour of the kidneys and the ureters. And any kind of urodynamic studies can be done for any voiding dysfunction and any abnormal urinary tract problems. And that's on, as I said before, it's on page 456. It starts there. These are the serum blood tests that may be done. We've already talked about BUN and creatinine, and we haven't talked too much about serum electrolytes, but as you remember, the functions of the kidney is the production of renin, which helps with the regulation of blood pressure, and release of renin is stimulated primarily by the decreased pressure in the afferent arterioles of the glomerulus. Remember also that the kidney functions to produce erythropoietin, which stimulates red blood cell production by the bone marrow. And it also metabolizes vitamin D in its active form, which is important, especially with calcium. So those may be some red flags for us as we look at our serum blood tests, but know that there are a lot of other differentials that you have to think about as well. Okay. We're going to start talking a little bit about urinary tract infection and vesicoureteral reflux. It's that word I can't hardly say. Anyway, UTIs. UTIs, as you know, we've talked, hopefully you've listened to the lecture on Chapter 69 in IGI, but it's caused by bacteria that ascends from the outside, the urethra, into the bladder. And from the bladder, bacteria may continue to ascend into the upper urinary tract. Usually fecal bacteria is most common cause of UTIs, and that's probably approximately 80%. So here are some of this slide goes over some of the anatomical and physical factors that predispose to urinary tract infections, and they include females because of the short urethra, which provides a real ready access for invasions of different types of organisms. The males, there's increased incidence in uncircumcised infants, especially younger than 1 year of age. There also could be the child could be predisposed because of urinary stasis or the vesicoureteral reflux, sexual activity in adolescent girls, any kind of urinary tract obstruction, and constipation in the child can also cause a UTI. This slide just goes over the different signs and symptoms in the infant versus the child. So we'll first start with the infant. Fever, they may have hypothermia in the neonate. Irritability, difficulty urinating, change in urine odor or color, poor weight gain, feeding difficulties. In our child, the clinical manifestations may be abdominal or suprapubic pain, voiding frequency, voiding urgency, difficulty urinating, new or increased incidence of enuresis, that nighttime bedwetting, and the child may or may not have a fever. Under our diagnostic evaluation, we're going to get the history from the parent. We'll do our physical exam, do a urinalysis, and do a urine culture and sensitivity. On our therapeutic management, we'll eliminate that current infection, identify any contributing factors, especially if the child maybe has constipation, predisposes him or her to UTIs. We want to prevent urosepsis, and we want to preserve that renal function. Very, very important. So our nursing considerations, we want to monitor I&O, we want to observe for signs of dehydration in the infant and the child, administer antibiotics as ordered, obtain daily weights, encourage frequent voiding, especially in the toilet-trained child, because as children, they'd rather play than pee or poop. So want to make sure that we remind them. Especially, I love how kids always kind of dance around, and you can always tell the hand goes right down to the genital area, and that they have to go potty, but they just don't want to take the time to do it. So it's really cute. Anyway, we also want to encourage increased fluid intake, very important, and it's important to educate the child and family as well. We're going to take a break right here, and we'll continue on another web link for the vesicoureteral reflux. Okay, talk to you in a minute.